Greetings students, this PowerPoint is going to cover nausea, vomiting, and GERD. So we'll start with nausea and vomiting. Nausea is just some sort of feeling that results in discomfort in the epigastric area and a need to vomit. And then vomiting, of course, is the actual forceful ejection of partially digested food. Many different causes could be GI disorders, infection, pregnancy, metabolic disturbances, chemotherapy. So there's quite a few factors that can influence nausea and vomiting. Other clinical manifestations could include anorexia with loss of appetite, weight loss, and then with prolonged vomiting, we start to worry about fluid and electrolyte balances, and then possibly metabolic acidosis or metabolic alkalosis. Our nursing assessment begins with identifying the source, if there's any type of trigger, how long has this been going on for, and characteristics of the MSS. So is it a bile color? Is it brown or resemble like a coffee ground type of MSS, which could reflect gastric bleeding? So just kind of follow up on the assessment of the type of MSS and characteristics. Nursing implementation includes keeping the patient in PO. If the vomiting is very severe, we can implement IV fluids to help maintain a normal volemic state. We can also do an NG tube to help with gastric decompression, and then of course monitor I's and O's, vital signs, and monitor for signs of dehydration. We also want to implement aspiration precautions. We don't want patients to potentially aspirate on their own emesis or vomit. Nutritional therapy includes, as we discussed, the IV fluids, especially if they're unable to tolerate oral intake. If they can tolerate oral intake, we want to encourage just small sips of water about every 15 to 20 minutes. Other things that are good are carbonated, room temperature beverages like a Sprite or a ginger ale, and then bland foods like dry toast, crackers, gelatin, and then eventually you can progress to high carbs and low fat diet. We just want to be careful to avoid over distension and not eating or drinking too quickly. That could possibly aggravate the vomiting and nausea. As far as patient and caregiver education, we want to teach them how to manage and prevent nausea and vomiting, maintain that normal fluid and electrolyte balance with nutritional intake. Other things to consider: keeping the patient comfortable, avoid sudden position changes that could possibly aggravate nausea, and then of course notify the healthcare provider if we suspect a medication could be the cause of these issues. And then other types of therapy that can be beneficial include acupuncture, ginger, and peppermint. With our older population, ideally we want them to, with all patients, minimize or stop the nausea and vomiting, keep our electrolytes within a normal range, and then maintain adequate fluid and nutrient intake. With the older population, we are really carefully monitoring them for signs of dehydration. They're very sensitive to fluid loss. And with rehydration, you also have to be careful because many older adults have comorbidities such as heart failure or renal failure. So we would have to be very careful with IV fluid replacement and just gentle rehydration because we wouldn't want to give them too much fluid too quickly. And then of course the aspiration precautions as well. An aspiration just means that food or liquid or fluids, instead of going down the esophagus into the stomach where it's meant to go, it accidentally goes down into the trachea and then down into the lungs, which is problematic. It can cause an aspiration pneumonia. So if a patient's vomiting, we want to try to encourage them to turn to their side or sit up, so to limit the risk of aspiration. Moving on to esophageal disorders. So with GERD, this is a chronic syndrome of mucosal damage, and it's due to the reflux of stomach acid into the lower esophagus. And the most common cause is an incompetent lower esophageal sphincter, meaning that little sphincter that's supposed to be closed between the stomach and the lower esophagus gets a little leaky, and so it starts allowing that reflux of stomach acid into the lower esophagus. And stomach acid, obviously very acidic, and can be very painful when it irritates that lower esophagus. And oftentimes patients complain of like a burning type of sensation or a gnawing type pain. And then factors that can affect the pressure associated with the lower esophageal sphincter include certain foods, drugs, obesity, smoking, and a hiatal hernia can also contribute to LES pressure. Picture here on the pathogenesis of GERD. You can see the lower esophageal sphincter right here. We want to ideally keep this nice and closed when food isn't actively going down from the esophagus into the stomach. And then you could see how stomach acid can reflux back up the lower esophagus and cause mucosal damage. Heartburn is the most common clinical manifestation. Patients might also have some dyspnea, or dyspepsia, regurgitation, where they kind of have a acid taste in their mouth, and possibly even respiratory symptoms. The one I see most commonly is a cough, like a chronic cough that doesn't go away. That could be an indicator of uncontrolled GERD. Complications of GERD include esophagitis, where you actually have ulcerations that lead to scar tissue, strictures, and then that can cause issues with dysphagia, difficulty swallowing. And then Barrett's esophagus, this is a severe kind of chronic form of esophagitis that involves metaplasia of cells, and it's a huge risk factor for esophageal cancer. So anytime you see Barrett's esophagus, you should associate that with increased risk for esophageal cancer. Other complications, you can have some respiratory involvement, cough, bronchospasm, and even dental erosion if that stomach acid makes it up towards the teeth. Diagnostic studies, so oftentimes this is usually diagnosed by history and physical exam. If that's not sufficient, an upper GI endoscopy with biopsy can be done, especially if there's concern of Barrett's esophagus. A biopsy would be very beneficial. Barium swallow, monitoring pH. But again, usually we're going to be able to diagnose this based on the history and physical. So what our patient is telling us and what we assess. Patient education is a huge component to GERD management. We want to encourage these patients to have a low-fat diet, try to have small, frequent meals instead of like a big, just 2 big meals, a day. That's a lot harder on their stomach and digestive system rather than having those small frequent meals. Also avoid caffeine, alcohol, and smoking. Those can be really aggravating for GERD. And then after they eat, they want to maintain an upright position for about 2 to 3 hours. And also a good idea to avoid really tight clothing at the waist or bending over after eating. And certainly don't eat 3 hours before bed, because then the patient's going to go and lay flat and they could have that reflux of stomach acid into the esophagus just because of the gravity from laying flat. Also, weight reduction is beneficial. And then good news, there are a couple different drug classes that we can use to help manage GERD. So drug therapy focuses on decreasing the volume and the acidity of the reflux. Can help improve the LES function and increase esophageal clearance and ultimately protect that esophageal mucosa. So your most common and your most effective medications are going to be your PPIs and your H2 receptor blockers. You also have like antacids like Tums and a couple others, but PPIs and H2 receptor blockers are your most common. And most patients that you will take care of in the hospital are usually on some form of PPI like Protonix or pantoprazole, and they might not have a history of GERD, but when you're in the hospital and you're sick and your body's under a lot of stress, fighting illness, that stress can increase risk for a gastric ulcer. So that's why a lot of your patients are on Protonix prophylactically to prevent and lower the risk of developing a GI ulcer. No specific diet that they really need to follow. It's more of avoiding their triggers. So if caffeine's a trigger, limit caffeine or avoid it. If spicy foods flare up their symptoms, limit spicy foods. Also avoid milk and eating before bed, and then again, those small frequent meals are best. In really extreme cases, we can do surgical therapy to help enhance the LES function. This is pretty rare. Most patients, thankfully, are able to respond well to PPIs and H2 receptor blockers. So we have a question. After the nurse teaches a patient with GERD about recommended dietary modifications, which statement by the patient indicates that the teaching has been effective? A, I can have a glass of low-fat milk at bedtime. B, I will have to eliminate all spicy foods from my diet. C, I will use herbal teas instead of caffeinated drinks. D, I should keep something in my stomach all the time to neutralize the acid. So if you chose C, you are correct. I will use herbal teas instead of caffeinated drinks. So this is our best answer because caffeine is a known risk factor for GERD. There was a question about, or an answer about the patient eliminating all spicy foods. They don't have to necessarily eliminate all spicy foods. It really just kind of depends on a trigger, but this is a good alternative to the caffeinated drinks, doing herbal teas instead. So that's our best indicator that our teaching has been effective. Thank you.